Hey everyone, welcome back to Cutting the Boards. In today's video, we're going to be diving into neck trauma, including zones of the neck, vascular and esophageal injuries, airway emergencies, and arterial control. These are all extremely testable and clinically important, so let's get started. When it comes to neck trauma, it's always important to identify what zone of the neck an injury has occurred in, as it's going to guide your surgical approach when you're dealing with these injuries. So zone 1 is from the clavicle to the cricoid cartilage, and these injuries are usually accessed by a median sternotomy. Zone 2 is from the cricoid to the angle of the mandible, and these are most usually accessed by a lateral neck incision. And then zone 3 is from the angle of the mandible to the base of the skull. As you can imagine, these can be very challenging to deal with and may require jaw subluxation or even strap muscle release for exposure. For asymptomatic blunt trauma, the workup includes a CTC spine and a CTA neck. For asymptomatic penetrating injuries, you would get a CTA neck, and then you would also evaluate for esophageal injury with an EGD or an esophagram for injuries that occur within zone 1 and 2. In contrast, if the patient has any symptoms including shock, active bleeding, expanding hematoma, airway compromise, subcutaneous emphysema, stridor, dysphagia, hemoptysis, or new neurologic deficit, these are all hard signs of injury and the patient requires emergent surgical exploration. Don't delay for imaging in these cases. These are operative injuries until proven otherwise. And if you get this question or these symptoms on the ABSITE exam, the correct answer is always going to be to go to the OR immediately for exploration. When thinking about injuries of the internal carotid artery, the distal ICA is the most common site of vascular injury within the neck. If the vessel is completely occluded, you would manage medically with heparin or Plavix. If it's partially occluded and symptomatic, you would start with a covered stent, and if that fails, you would proceed to an open repair. For asymptomatic partial occlusions, medical management with anticoagulation and then a repeat CTA prior to discharge is usually sufficient. Other treatable lesions like carotid AV fistulas, pseudoaneurysms, or symptomatic dissections can also be handled with endovascular stenting. We will talk more about esophageal injuries whenever we get to the esophagus chapter, but esophageal injuries in the setting of trauma are rare but deadly if missed. The approach usually depends on the level, so for a cervical esophageal injury, you would approach through the left neck. For an upper thoracic injury, you would approach through a right thoracotomy, and for a lower thoracic injury, you would approach to the left through a left thoracotomy. Remember, these are surgical emergencies. Even small perforations can rapidly lead to mediastinitis if not repaired early and emergently. A cricothyroidotomy is indicated when standard intubation is impossible and the patient is losing their airway. Common scenarios include severe facial trauma, massive bleeding, or airway obstruction from edema. On the ABSITE, they love to test who gets this. It's your can intubate, can oxygenate scenario. It's quick, life-saving, and appropriate in adults, but avoid in children under 12, where a tracheostomy is safer. Laryngeal fractures and tracheal injuries are also airway emergencies. Look for crepitus, stridor, subcutaneous air, hoarseness, or respiratory distress. The first priority is to secure the airway, sometimes with a cricothyroidotomy. Definitive management involves primary repair, often supported with strap muscle reinforcement, and almost always requires a temporary tracheostomy to allow for edema to subside. Finally, let's talk about arterial bleeding within the neck. So vertebral artery injuries, as well as external carotid artery injuries, can usually be ligated or embolized with little consequence. The commoner ICA, however, ligation carries a stroke risk of about 20%, so it's typically reserved for uncontrollable hemorrhage. The principle is to control the airway first and then bleeding, and remember, airway loss usually kills faster than hemorrhage. Let's summarize some key takeaways from this lecture. So divide the neck into zones because it determines your approach, and you should be able to know the zones of the neck and know based on where an injury occurs what type of approach you would take. Hard signs always buys you an immediate trip to the OR for surgical exploration. ICA injuries are often treated endovascularly. Esophageal injuries depend on the level, so it's important to know where along the esophagus and what approach you would take. And then a cricothyroidotomy is a life-saving procedure that general surgeons should be able to perform for can intubate, can oxygenate situations. And then it's always important to remember the airway first, especially when it comes to any hemorrhage within the neck. Thanks for watching Cutting the Boards. I'll see you in the next video, where we'll continue our trauma series with thoracic and abdominal injuries. As always, study smart, stay consistent, and your future patients will thank you for it. We'll see you in the next video.